When you finished fellowship, how much dosimetry knowledge did you have?
I think I can start with that one. So first of all, a lot of the really newer data has come out right in the last decade, pretty recent in like the 2020s. So I think when we graduated fellowship, in terms of actual thresholds, it was a little different. But in terms of the practicality of dosing, the first time I had to dose a patient myself in terms of the nitty gritty and how to do it. And I really didn't feel that prepared. Fortunately, I had a lot of mentors to go back to, but I wish that I'm trying to do it now with my trainees. I'm actually trying to talk a lot more. We're busy, right? So we're mapping, we're treating, but sit and just say, listen, this is the volume I'm seeing, this is the dose I want to hit, and this is actually the vial I'm going to order. So I think I'm trying to purposefully do a little bit more with my trainees because I personally didn't really feel prepared when I started as an attending.
When did you finish fellowship?
2020.
Okay, so I finished in 2009. In 2009, there was no concept of dosimetry, and I trained at Northwestern, which is largely kind of spearheaded radioembolization, and we basically did everybody the same, 120 gray, single compartment, and especially as a trainee, you don't know any better, you don't know any different. That was before we were starting to do radiation segmentectomy when I was a fellow, so we had no idea at that time, and you can clearly see the evolution that's happened, over the 14, 15 years since.
Absolutely. I mean, 6 years after that, when I graduated from Northwestern, I had no idea how to do dosimetry because it wasn't part of our, training. We'd be there as get access, get into the vessel, then, have the delivery of this GBQ vial that came out of nowhere. So I knew nothing coming out of fellowship as far as dosimetry specific, calculations, what to go for, and I learned a lot of that on my own and asking mentors and people like you.
And I think part of it is that, in fellowship, you're learning, it's not like you're just learning about radioembolization.
Yeah.
That's one of 25 things you have to learn, right? So you have to learn everything else. And so are you really going to spend a lot of your capital learning about dosimetry? And you may end up in a practice where you're not doing any liver-directed therapy, right? So then, you have to kind of weigh the importance of it while you're in training. And so I think for most of us, you end up learning it afterwards.
Uh-huh.
Yeah, you got to figure out how to do the procedure before you can make
Exactly.
the dosimetry part.
Yeah.
I was a lot like you, Kirema. I knew conceptually how it worked, but you give me a patient and say, figure this out. I was like, I'm screwed.
And I'm sure you could do the mapping, you would do your cone beam CTs, the procedure, you got it. But when it came to actually the dose and dosing, yeah.
And it gets even more confusing because the different Y90 products have different dosing, different thresholds, different targets, which makes an added
another
complexity.
Challenge. Now,
in addition to that, too, it's just there's not just one option, too, as far as like what do you dose, what's the threshold, you can go higher. There's just so many options to do that then, you don't know what to do in the beginning. And then I think now we're getting into this era of a lot more guidance of dose and everything. So.
And I think that's a very important point. It's still evolving and evolving a lot. So I'm sure we'll get into that. But
so I wanted to do this so that if let's say you just finished fellowship, you would be able to listen to this and you kind of get some guidance on how to dose. I think that, to me, it would solve a lot of the problems that I would have gotten had I been able to had the same opportunity. Zach, you gave a physics talk for Jess recently, and you talked about Y90. Can you just hit it real fast? How does Y90 work?
I think the easiest place to start is what Y90 doesn't do. And for me, I don't think of it all as like ischemic embolization like you would a TACE. It's conceptually a very different procedure. If we could go back in time, maybe we would call it transarterial brachytherapy, the idea of taking tiny little seeds with radiation and putting it homogeneously throughout a distribution to slowly emit radiation. That the radiation is going to either interact with water molecules to eventually cause free radicals to cause DNA damage, or at high enough doses directly with the DNA itself. And then we can talk about your treatment intent, because that's going to very much change how you want to dose it, because you're going for different mechanisms of cellular death, depending on whether you're doing a palliative or an ablative intention.
Okay, so that was cloud level knowledge, breaking down water molecules. All right, so you hit on this where target dosing is important, right? So what do you guys think? Are you looking at, when you're looking at dosing, and before we talk about the simplest way to do dosing and the most complex way to do dosing, when you're talking about target dosing, looking at target dosing to perfused territory, target dosing to tumor, target dosing to normal. What kind of strategies are you looking for there? What are your minimums? Do you have maximums? What do you think about when you're dosing?
So the best answer is it depends. And that's what makes it so hard, right? Because it's not a one size fits all. And I think we're going to go into it, but when you have a person who has a single 3 centimeter tumor versus the next guy who has a single 15 centimeter tumor versus the next guy who has 15 tumors evenly scattered throughout the liver, your goals and then your thresholds are all going to change. And so you have to start thinking about all your variables when you do this based on those are 3 of the more basic scenarios, right? So in one very quick example, a 3 centimeter tumor, you're not really worried about the normal liver anymore. In a patient with 15 tumors throughout the liver, you are very much worried about the normal liver. So then you have to kind of change how you're going to treat your threshold.